Well, welcome everyone to another evening with wonderful speakers through the Distinguished Speaker Series. And thank you all for coming out tonight for a very special presentation that awaits you this evening. And my name is Diane Cheseldine. I'm the founder of the series, but that's enough about me, because let's get to the question, who are you? And I think that might be part of the reason that you're here this evening. So, but before we start to answer that question, I do want to thank the Distinguished Speaker Series Committee, and in particular, my colleague Dr. Samir Bhattarai. I asked him if he would do this presentation introduction, and he said no, so I still have to get you involved in this, Samir. Anyway, he was very helpful to make the initial connection with DRI and with Dr. Grzymski. I also want to thank our publicity office, because they do a wonderful job of creating the beautiful flyers you may have seen, and also putting the word out to the faculty, the staff, and the students, and to the community at large. So we want to thank them. Now, let's get back to that question, who are we? Many of you may have heard of this program that has taken place this fall, isn't that right? Was it September? And through the collaboration of Desert Research Institute and Renown and 23andMe. And people have been asking me for a couple of weeks, is he going to talk about this? Is he going to talk about that? And I said, I'll see you here on the 15th. I don't know. So Dr. Grzymski is going to tell us more about that unique project and what it means not only for Northern Nevadans, but possibly the world at large. But I would like to say a few words about our speaker. And I definitely have to look at my notes for this, because his background is extensive. So let me put on my glasses. And this is just a small bit of information about Dr. Grzymski. He is the Senior Director of the Applied Innovation Center and is an Associate Research Professor of Microbiology and Computational Biology at the Desert Research Institute. He is also the lead investigator on this project that he'll be talking about. I would also like to add, however, that his DNA has played an important role in his life outside the lab. Close analysis tells us that he's an avid tennis player, a runner, a cook, and a wine collector, and perhaps, if I may make an assumption, perhaps enjoys wine tasting as well. So it is now my pleasure to introduce Dr. Grzymski to you.
Thanks, Samir. I turn my timer on so I don't lull everybody to sleep. So over the next 4 to 4.5 hours, I'd like to comprehensively teach everybody about human genetics, of which I myself am a neophyte. So well, first of all, who here, raise your hand if you're actually participating in the Renown and DRI study. So a fair number of people. There's a 3,000 person wait list right now. And you've probably heard the study has received a lot of attention. So what I want to do today is kind of take you through the motivations, but first by stepping back a little bit and talking about the history of science and how we got to where we are today in this incredible world of information technology, molecular biology, and the promises of health and health discoveries. So Oh, I thought I had another slide. So before I get to Hippocrates, I just want to thank the many, many, many people who, represent the title, Renown, DRI, and me being up here today. A study of this size is not possible without a incredibly collaborative group, both at Renown and DRI and 23andMe. And so all of those people, too numerous to name, but I really want to acknowledge them. I also want to acknowledge the funders, the Renown Health Foundation in particular, and the Governor's Office of Economic Development. Without their support, this pilot study would not have been possible. So let's step back. Who knows who discovered DNA? Just yell out the names if you know. Yeah. Okay, you get a prize later. Somebody will buy you a free drink. So Watson and Crick everybody talks about Watson and Crick, so I'm not going to talk about them. I'm going to talk about all the other people that are responsible. Science, as complicated as it is, involves incredible observation, and whether the observation occurred 2,400 years ago when Hippocrates was around, or later, great discoveries in science occur when people are very, very observant. Hippocrates started talking about early concepts of inheritance, and this concept of us having stuff in us. He didn't know what it was. He didn't have a microscope powerful enough, but that there was something in man and there was something in woman, and it was passing to their progeny, and that concept of inheritance he called pangenesis. It was wrong, but it was a good try. About 1,000 years ago, the most famous Arab surgeon, al-Zarahi, actually talked about hemophilia, which is an X-inherited disease, and he talked about the genetics of inheritance of hemophilia. And so very early on, people knew that there was something in us that contained information that passed on some sorts of traits. Here's the friar that is most famous for his studies on peas. This is Gregor Mendel, really probably the father of inheritance and incredible experimental observation in his patch of dirt as he grew thousands and thousands of different types of peas. And he really discussed and talked about the concepts of inheriting traits, and that began in the monastery. For those aspiring scientists out there, I'll say that his paper, which I would recommend reading in the original German, published in 1865, had 3 citations in 35 years. 3. Anybody today who published a paper that had 3 citations in 35 years would be considered a failed scientist. So his study got buried. People didn't understand the importance of it. They thought it was a study about how to grow peas, and it wasn't. It was an early study on the inheritance of traits. This is Friedrich Miescher. He actually started doing experimentation on pus from people who were sick, and isolated an acid that he and his colleagues thought was extremely unique and contained some new molecule in our cells, and he called it nuclein, obviously a derivative on nucleus, and what that was coming from lymphocytes was a crude extract of nucleic acid. Thomas Hunt Morgan, an American, really is the father of model organisms. He studied the fly and talked about the concepts of genetic linkages and chromosomal inheritance. So now we're getting at, really, really advanced concepts related to, certain aspects of traits that are closely related on the chromosome, and when we have homologous recombination, those traits pass on. Incredibly advanced stuff. In 1933, he won the Nobel Prize in Medicine. And then this brings us to Rosalind Franklin. For those of you who really want to learn about the incredibly brutal history of science and its competition and why it leaves us miserable and causes people like me to collect hundreds of bottles of wine, it's because of the fierce competitiveness when people are at the cusp of incredible discovery. And so Rosalind Franklin was working in London. This incredibly famous photo called Photo 51, probably one of the most famous photos in X-ray crystallography, was given to Watson and Crick without permission and allowed them to start really understanding the structure of the double helix. And so important to really talk about people before Watson and Crick because they really set the stage and made it possible for their foundational discoveries that came out in 1955. And so that's a little bit of the early history of DNA discovery. And so I want to fast forward to June of 2000 when Bill Clinton had this incredible press conference, and these two people who actually hate each other had to sit in the same room and talk about the private sector and the public sector going on a race to decode the human genome. And on the left is Craig Venter, on the right is Francis Collins, who is the head of the National Institutes of Health. And they formed this race. Craig Venter formed a company called Celera, and they used his technology, which was to take DNA and basically put it in a Vitamix and sequence it and then put it back together using a computer, where Francis Collins took the very meticulous approach of starting on a chromosome and starting to sequence and putting it together. What isn't talked about is that without the meticulous approach, Venter probably wouldn't have been able at the time to reassemble the genome without that scaffold that was made by the $3 billion investment from the NIH. So in 2000, we had 90% of our genome sequenced, so approximately 2.7 billion base pairs. And at the time, scientists thought there'd be hundreds of thousands of protein coding sequences, proteins that make up your hair, your nails, your face, everything inside you, the brain. How many proteins must be in the brain? Hundreds of thousands. And what they found was that the protein complexity in chromosomes was actually much smaller, only about 20,000 protein coding genes. And so if you're a scientist and you think you're going to take the human genome, you're going to decode it, and then you're going to be able to find out protein A causes pancreatic cancer, protein B causes diabetes, protein C causes heart disease, and you only have 20,000 to choose, and there's way more than 20,000 pathogenic things that can kill you, the story becomes much more complex. At the time, and I start with the cautionary tale, and then I'm going to end with, everything's going to be fine. We're going to take care of everything. At the time, I think this was Clinton, not someone to over-exaggerate, said that this discovery was going to revolutionize the diagnosis, prevention, and treatment of most, if not all, human diseases. So, fast forward again 10 years later. Headlines from the news. A decade later, genetic map fails to yield new cures. The Human Genome Project, did they oversell the revolution? I mean, it's not nearly as good as the Beatles. Scientists were talking about deflating the genomic bubble, that we didn't have the capacity to make the leaps from this code to curing diseases. And I think if you know a little bit about how medicine works and the tremendous amount of time and investment, maybe 10 years they shouldn't have opened their mouth about 10 years. It should have been 30 years. It takes 10 years just to get a drug going. But the point is that no single aspect of health or health care can be linked and found to cure, all of our problems. No single technology can do that as well. And that seems like an obvious cautionary tale, but it allows us to think about health outcomes a little bit in a more detailed way. And so up here I've listed some health outcomes, and what they indicate is that there are multiple interactive factors. So if you're a statistician, this is like manna from heaven, because you've got just a tremendous amount of interactive diversity to work with to solve problems. And so if we go down this list, I know there's at least one medical doctor in the room, so he doesn't get to open his mouth, but age, sex, family history, smoking, poor diet, high blood pressure, diabetes, physical inactivity, stress, poor hygiene. What do you think that's a risk for? It's a risk for a lot of things, but in particular, if I put cholesterol up there, everybody would have gone ballistic, heart disease. So age, sex, and family history, not really things that you can control. You're going to age. Yeah, hopefully. And you are who you are, and your family history is who your family history is. All of these other things are behavioral. So it's funny that I'm talking about the biggest population health study funded by a community hospital in the world, and we're going through the fact that behavior probably controls most of your health. But again, cautionary tale and really setting the stage for what we're trying to do with the study. So behavior is everything, and it's really, really hard to change. So I've eliminated the list, and I've gone down to two things: family history and high blood pressure. And I did that because we know that actually in coronary heart disease, bad genetics really does double your risk for coronary heart disease. So unfortunately, if you have bad genetics, you have twice the risk that I do. I've got great genetics. I'm 95% more Neanderthal than everybody in this room. Interestingly enough, Franklin and Wong found that bad genetics and good behavior eliminates bad genetics, and you're back with 1x the risk, the normal hazard ratio for living and being of a specific age and having heart disease risk. You're going to have a myocardial infarction. You have a 1x risk with all other things being equal. If you have bad genetics, you have a 2x risk. But if you have good behavior, you eliminate that. And so that's really interesting, because that tells us that there are certain aspects of genetics that we can control, and there are probably certain aspects we can't. High blood pressure, on the other hand, anywhere between 2 and 3.5 times the risk for coronary heart disease. Now, high blood pressure is, in fact, caused in certain cases by genetics, but it's also caused by, a lot of other things. Those other factors that I talked about earlier: poor diet, physical inactivity, stress, poor hygiene, et cetera. People that don't brush their teeth, they find that their oral microbiome actually is responsible for certain aspects of lipid profiles in blood serum. So, even just brushing your teeth is really good for you. The problem with these gross generalizations coming from somebody who has a PhD in biophysics and isn't a medical doctor is that they're just statistics. They just tell you that your risk is 2x. If we had, there are known risk factors for diseases that are 1 in 3.5 billion. So basically, one person on Earth right now has a chance of developing a particular disease because of a risk factor that is that minuscule. So then if we said, well, that there are certain aspects of that 1 in 3.5 billion that are going to double your risk. Who cares? Then you're 2 in 3.5 billion. That's still not great odds if you go down to the casinos. These studies that ascribe these 2x and 1x risk, they're scientifically validated, but they have little regard for other aspects of the determinants of health. We know that people who live in socioeconomically depressed areas have a higher risk for coronary heart disease than is predicted by all other measures. So you can put things into a model, and if you don't factor in those other factors, those other determinants of health, you don't do a good job of telling people what the real risk is and whether or not they should truly change their behaviors, or at least try to change their behaviors. So it's really important to start linking all of those things together, and I think now we have the capabilities of doing that with the fact that, you know, you can do computational analysis of these studies now on a MacBook Air. You don't need supercomputers. You can do statistics on studies of this size relatively easily. Soon you'll be able to do genome sequencing on an iPhone. As of now, you can do sequencing on a device like this. This is a DNA sequencer that we use in the lab. It plugs into the USB drive of a laptop computer. And this single instrument running for 7 days will give you the same information that I talked about in 2000 that cost $3 billion. This costs $159. So things are really changing, and I think now we have the ability to start figuring out what really determines health. One of the things, now some cute phrase, the ZNA is the new DNA. Actually, it's not new. We knew this all along, that the way you act, affects your behavior. There's a reason why when you go to get life insurance, they ask you if you have any intention of being your own pilot or scuba diving, because people who do that tend to die more frequently than people who don't. So where you live also affects your health, unfortunately. So this is a great quote from the head of the Robert Wood Johnson Foundation. "We know that a child's life expectancy is predicted more by his zip code than his genetic code." That's a little bit sad, I think, in today's day and age, especially in the United States. That's an entirely different discussion, especially in a November of an election year. And I'm happy to come back and give that lecture too. But the point is that as we start to learn about your social history through analyzing gross Twitter feeds in Reno, as we start to understand the aspects of living in a specific zip code that cause behavior change. Is it because it's got crappy streets and you can't walk to the store, or is it because of other things? We can start to piece together incremental ways to make people healthier. A doctor isn't going to tell you, yes, sir or ma'am, you need to run 2.5 miles 4 times a week, but it's really only going to improve your odds of not having a heart attack by 2.78%. I mean, you'd be like, and by lifting your arm up 13 times, you do the exact same thing. And it's snarky, but it's very true. We don't do a very good job of communicating to people how to make themselves healthier and how to really empower them with decisions. And I think one of the really awesome aspects of the collaboration between Renown and DRI is we're starting to think about, and Dr. Slonim, the CEO of Renown, talks about this all the time, health before healthcare. How do you give them the information to be healthier? And one of the ways to do that, we think, is by giving them access to this incredibly sophisticated information that's produced by 23andMe. So population health challenges in Nevada, compared to other states, are really profound. We have social challenges, we have economic challenges, we have environmental challenges, I'll talk about that. We have high Medicaid costs, we have poor health outcomes, we have very low public health funding. In fact, we have the lowest, number 50. We receive $24 million a year from the National Institutes of Health. UCSF, right across the hill, has 25 projects that receive more money per year, just at one research institution. Northern Nevada, here, for those who are geographically confounded, this is Reno, half of Lake Tahoe, Salt Lake City's over here, Sacramento's over here. We have one tertiary care facility between here and here, covering this entire region. That's the equivalent of having one hospital with tertiary care, so that's like real trauma stuff, in New York, New Jersey, and Pennsylvania, which is astonishing if you think about it, especially if you've been on the New Jersey Turnpike. One tertiary care facility managing this entire population. That's a real challenge. I'm not suggesting we start popping up hospitals, they're really expensive, but we need better tools at our disposal to help with the problems, given that they're in red, population density super high, there's Vegas, very low population density throughout the state, throughout the rest of the state. So we need better tools to help us solve these problems. And that brings up the question of how do we start managing health challenges in this growing community with the backdrop of this Northern Nevada geographically isolated population problem. This is a map of the Reno Sparks and Carson City area. This was made by Dave, who's in the audience. And thank you, Dave. That's because my finger's covering it, sorry. So the shaded area is the density of population that Renown sees. Purple here is the tertiary care facility, and these are the satellite hospitals. And then what Dave did was he overlaid or underlaid population growth estimates from 2016 through 2021 in the region. And so you can see up in Spanish Springs, they're expecting very high population growth down in the southeast and in the west. So we have a growing community. We have growing challenges, and we again have this single TERT care facility that needs to manage our population health problems. We also have an economic disparity problem. The United States does in general, but we're talking about Northern Nevada. In certain parts of Reno Sparks, between 60 and 100% of all households are below the poverty level. This hopefully is not a surprise. And in many regions, up to half of the households are. So when we talk about genetics, we're talking about human research and access to UCSF clinical trials and the cutting edge. We're really not talking about those people. We're talking about, me. I can call the CEO of Renown and ask him for help. I wouldn't use that privilege, but it's available. And that disparity is a huge problem. People who are scared about having cancer have the ability now to go online and take tests that are not validated by the FDA that will tell them certain aspects of risks to cancer. They cost $1,000. The populations in red don't have access to that. And so when we talked about starting to build a community health program and linking lots of data and starting to think about how genetics might play in cancer, upwards of 50% of risk factors, certain aspects of heart disease, 50% of the risk, we said it would be inappropriate to not have it be offered for free to the community and to see how that freeness gives people the ability to respond and how their behaviors might change. It's one way of leveling the economic disparity playing field that pervades healthcare. And there are severe problems in Nevada, but specifically Washoe County in general. So I just want to bring your attention to the three big ones: heart disease, cancer, and chronic lower respiratory disease. Heart disease, 263 age-adjusted deaths per 100,000. Compared to the United States, almost 100 more in Washoe County. Cancer, we're doing pretty well. We're only, approximately 10 above the United States. But certain cancers, which I'll talk about later, we have more. Chronic lower respiratory disease, extremely significant. 20 more deaths. I mean, it's lower, but the point is there are profound healthcare problems in Washoe County, and adding really good subspecialists in heart disease, cancer, and respiratory disease are really important, but we need other tools to help us solve these problems. So if the lights were out a little bit, you'd see a common problem here, an inversion, and I use this to transition and talk about determinants of health beyond, very simple genetic associations: cystic fibrosis, single mutation, hemophilia. The determinants, whether they're social, economic, genetic, environmental, are really complicated, but they're potentially profound. So this is a massive inversion that occurred in 2013, this photo courtesy of the RGJ. And so we started asking about a year ago how we could start using the data at Renown in a completely de-identified way to help solve problems in healthcare, and start linking all of these data sets that we have very easy access to at Renown and DRI to help solve this problem of population health, health before healthcare. So in our data set, we have 1.4 million patients, 23 million provider encounters, 122 million lab order results in a 10-year period, 14 million prescriptions dispensed. With that type of data, you could start doing real statistics and understanding how the population is reacting to their problems, whether it's a problem with breathing because of this air, or a problem with their AFib, which is on the rise. You see it on the news. Things are always on the rise when there's a new drug out because they're trying to sell it. But this is real data from Renown, and this is the frequency of AFib between 2012 and 2016, and you can see it's increasing. And some of the scientists at DRI started looking at things like ozone, and the fluctuations in ozone that are seasonal. The fluctuations in PM 2.5, that's the really small particles that get caught in your lungs and cause problems, particularly if you have things like asthma. And we started finding correlations, and other scientists are doing this around the world. But in northern Nevada, with our unique population kind of locked in between the mountains and people not wanting to drive 80 all the way to Salt Lake City, we can start tracking individuals, and I use that word in quotes because everybody will start freaking out if people are tracking me. Individual is P1973.7. We don't know anything except your sex and your age, but we know that person came into the hospital and they had a problem, and we can track their outcomes, and we can start linking certain aspects of health to your outcome. Are you responding well to your medication? Are you responding well to whatever the palliative care that you're receiving is? And are you at potential risk for some genetic associations with disease? And these environmental determinants are really profound, and they're very variable. So the data salad on the left, you don't need to know all the data points, but these are all aspects of breathable air quality changes that we track at DRI, things like PM 2.5, carbon monoxide, nasty nitrogen compounds that come out of diesel engines and cause radical DNA damage. So that's stuff that actually, when it gets inside you, particularly in your lungs, it can cause a mutation that can eventually cause cancer, stuff like that. And we're starting to look at the relationship between these determinants with adverse events. So here the team plotted pulmonary adverse events, asthma, COPD, and emphysema, where they're occurring, but also we can start looking at outcomes. And once we have access to this incredible genetic data, we can start really thinking about building models. And so here, Jim Metcalf, who spent 30 years at SAS Institute building statistics software, and thanks to the Governor's Office of Economic Development, we were able to steal him and bring him to DRI. He started looking at things like, what is indicative of child and mom stays in the hospital, and can we start telling Renown and other hospitals how to be wary of specific variables. So we know that if you have a daughter in the hospital, they tend to stay less than baby boys. And that's for a variety of pediatric reasons, but babies that are born that are female are a little bit healthier, and so they stay in the hospital less. And that odds ratio, which is a statistic, is about 0.82, which is extremely significant. We know that the type of provider access, whether you're on Medicaid or you have private health insurance, also is indicative. And we know that probably makes sense. If you're on Medicaid assistance, you probably aren't eating as well. You probably aren't going for all of your checkups when you're pregnant. And so that determines your length of stay when you walk into a hospital. Whether you live in rural areas or urban as well. Again, probably access to doctors, information. But also days of the week impact your stay. Some of those are procedural and others are probably staffing. And what Duke University did was they started looking at nurse rotations and fatigue in their NICUs, and they started modeling how they could restaff their nurses in the NICU, and they found babies actually, based on the models, became healthier as they made these operations changes. This isn't, wild, access to incredible drugs. This is using data to help drive operations. And so, along with all the fancy stuff about 23andMe, we're thinking about how to use these types of data to inform decisions at the level of building better hospital operations, so we can even this bar so that everybody is along this one line of odds ratio. It doesn't matter whether you have Medicaid or private, you're going to stay in the hospital at the same time. It doesn't matter rural or urban. We're going to go and start monitoring rural pregnant expectant moms and get them to the point where when they walk into that hospital, their odds ratio is exactly the same as the person who lives in, pick your Reno zip code. Environmental determinants are incredibly profound. And so provocatively, I put up a map of all well water sites in Nevada. Nevada is a fascinating place geologically. We could talk about things like radon. We could talk about, but I chose to talk about well water because, my wife is a hydrologist, so I'm paying homage to her. But also, a lot of people living out here are on well water. I'm not suggesting by putting the cancer statistics for pancreatic cancer that it's linked to well water, but as we start to accumulate all of this data, we can start to causally link environmental determinants of health. In northern Nevada, we have approximately a decade earlier incidence of pancreatic cancer than the rest of the United States. Most of the United States sees cancer patients that have pancreatic cancer 60 to 70. In northern Nevada, we're about a decade earlier. And that's a problem, particularly because pancreatic cancer is one of those just awful cancers where your odds of survival are incredibly low. So, you know, everybody's like, is he going to talk about 23andMe? Well, I'm just going to give you all the answers in 2 slides. But the concept behind the study was that, you know, Nevada has gotten a bad rap in lots of ways. You know, we have poor funding. You know, everybody thought this was a casino state and a mining state, and it's a lot more than that. And so one of the things that we started thinking about, given, you know, announcements like the Tesla site coming, you know, Apple building a facility here, Switch building a facility, is that, you know, there's some really interesting aspects of northern Nevada. Besides the fact that you're 20 minutes from the mountains, you can do all this awesome stuff. It's a great place to live. But we think northern Nevada is a real population health model. We've got a single tertiary care facility. We've got a very well implemented electronic medical record database. We've got a multi-generational population. The combination of that, not found in places like New Jersey, San Francisco, makes for an ideal population health and genetic study location. And so we partnered with Renown and 23andMe to improve population health. We started with a 5,000 person pilot. Within 1 day, it was completely, quote unquote, sold out. We upped it to 10,000 the next day, thanks to some incredibly generous donors at the Renown Health Foundation. The intention is to expand it to a larger insurance-based population and ultimately to all of Nevada, and to start asking questions like, does behavior change when access to genetic information is given to participants at no charge? 23andMe has really good statistics on how people change their behavior by the questions they ask, but everybody in the 23andMe database, except for a few people in specific studies, have paid the $199 to take the test. That's what I did. Now we're starting to give it to people and ask them how they're responding to it. Doing this starts allowing us to better communicate and reach this incredibly broad catchment area with the hopes of solving some of the more profound problems in northern Nevada. We have, compared to the rest of the United States, poor child health outcomes. We've got a cancer problem, but so does the rest of the world. We have a very profound heart and vascular health problem, and we have a growing elderly care population that we need to manage. And using this combined approach is potentially powerful. So why did we choose 23andMe? Population health research requires true community level participation. It is not about you coming into my lab and me, you know, doing stuff to you. It's really about participation. And the entire model that was built by 23andMe and its founder, Ann Wojcicki, was on the fact that people, when they have access to this information, can both not only understand it, but they can use it to inform their own decisions. And as the knowledge grows, those decisions may more and more profoundly impact how you live your life. That's the incredibly idealistic concept behind 23andMe. And frankly, if you're a billionaire and you want to form a company to do that, and you're not on the New York Stock Exchange, you can think at that level. And when we talked to them and we met them and we started talking about how we wanted to do population health, our goals aligned. And so, yes, with 23andMe, you get these cute, you know, reports where you get to learn about deep sleep. I didn't need, this is, by the way, mine. I always feel like it's better to put your own data up than some random person. I didn't need anybody to tell me I'm less likely a deep sleeper. I mean, that's like every day of my life. didn't know I was potentially lactose intolerant. I mean, it's interesting because I really like ice cream, but fortunately saturated fat and weight, so the ice cream problem, I likely have a similar weight no matter what I consume. That's probably because I also drink a lot of coffee. But beneath the veil of these reports are incredible reserves of data that allow us to start mining the associations between aspects of your genetics and health outcomes. And so giving something to an individual was really important, making them participatory in research, both 23andMe's research, but our own research was really important. And making people feel that they're not human subjects, but they are actually participating and getting access to that same information that we have is and was a foundational part of why we launched the study with 23andMe. So, in my own world, this is my dad and me, and that's me and my little Lucas. We have a history of cancer, and I think as we start collecting this information about people, we can start figuring out, was the cancer because my father grew up in a coal mining town or because he got really bad dice of DNA? And if so, I maybe have as much as a 50% chance of having that same chromosomal abnormalities. And I kind of want to know that, not necessarily for myself. I think my trajectory is set based on the 44 years of previous behavior, some good, some bad. But I really want to know it for the future. And what we're finding when people come into the Renown study is whether it's the 25-year-old or the 89-year-old, that they're talking about, leaving a legacy for Northern Nevada, and I think, or all of Nevada, humanity as well. But really in this community, our quote unquote battle-born community, excuse me, I think that's really important. And that legacy is something that we want to continue, and we're doing really hard, thanks to the help of people like Stacy, who's in the audience, who works on Renown's incredible marketing team. We're trying to communicate that aspect of the study. We're not going to solve profoundly problems of disease in the next 5 years from a 10,000 person study. But as we start getting more and more community participation, the power of our statistical power increases. And our ability to figure out whether or not, my father's colon cancer, which killed him at 58, is something that I should be concerned about, or Lucas should be concerned about, will become more and more a reality. In the meantime, colon cancer is largely preventable if you go and you get your screenings and you make sure you have your polyps removed. So that's a cautionary tale as well. We're also lucky in Nevada that there are very few degrees of separation between institutes like TMCC and DRI and our incredible governor. And so how do you get people excited? One way is to get the governor to be the first participant in the study and to recruit all of these awesome community ambassadors, whether they were leaders in the Hispanic community, leaders in the Native American community, writing the Reno Mom blog. These people were influencers in their community, and they thought it was important to be early participants and to really talk about what they're learning in the study. And that's really important, talking about it. It doesn't take away the sacredness of data. It doesn't take away the respect that we have for the fact that, healthcare data is extremely sensitive and proprietary, but it allows people to start communicating what they're learning about their own genetic story, and I think that's really important. And so, having Governor Sandoval come, people who've allowed us to take their photo and publish them, former newscaster who's the head of community advocacy, making sure that the community, whether it's the Boys and Girls Club or today in Fallon, Winnemucca, Elko, where we were at recruiting and getting participants within our rural communities, Kristen Remington on the news, talking about the study, that's really what makes Nevada unique, and I think what offers hope in the future as we start to understand these people who are participating. And it's amazing because the participants are all over the map. This is an age distribution of our participants to date, 7,300 of them. Everything from 18 years old, that was the cutoff for now, to well into the 90s, wanting to be a part of this. The aggregate, disease and primary diagnoses of the people in the study are everything from a simple abnormal lab finding that brought them into the Renown system to issues of circulatory disorders, diabetes, respiratory, et cetera. It's all over the map. People who really want to know about what it is that makes them healthy some days and unhealthy others. Also people who want to know about their adopted kids, who want to know whether or not they really are 100% X, Y, or Z, wherever you think you're from, and the stories that you're told about your ancestry. The people in the study are both frequent flyers in the Renown Health system and those who've only been there once. And that's really important. So we have people who've been there more than 1,000 times. So very unhealthy members of the population, and people who, again, had an abnormal lab finding. If you run a lot like I do and you go to the doctor, and or you take a drug test, which happens occasionally, you may find you have blood in your urine, and that's because when you're pouncing up and down, it hurts your kidneys and you have blood in your urine. That's an abnormal lab finding. If you tell the doctor, Sunday I ran a half marathon at Disneyland with my kids, they're going to say, don't worry about it. Abnormal lab finding. There are people in the study who are super healthy, and there are people in the study who aren't. And as those numbers come up, the power to really affect the health of the population increases. People who are participating in our study are all over the map. We aren't actively recruiting socioeconomically, but we know that people are well represented in all of the socioeconomic strata that I showed earlier, and that's, again, really important. That also says to us that the person who can't afford the $199 test still wants it, and so giving it to them and allowing them access to the information is really important. And I think one huge failure of science is that scientists and doctors too often think that they know everything and they don't need to communicate it to people because they don't have PhDs or even bachelor's degrees, and that's nonsense. The FDA-approved reports at 23andMe are 80% comprehensible at an 8th grade reading level. So you can really learn about genetics. And once you start learning about it, you may find, is it the next slide? Yes, that you can start looking at papers and feeling that there is promise to those dastardly reports that came out in 2010 about the failures of the genome bubble. So up on the left, huge study on genome-wide associations using electronic healthcare records to identify new loci on chromosomes for influencing blood pressure variation. So why is that important? Well, that tells us that this does work as we gather more and more information. What it tells GlaxoSmithKline is that if there is a new loci on a specific protein that happens to have a site available for a small molecule to bind to it, then maybe we can start coming up with new drugs for things like blood pressure. Development and validation of a clinical cancer genome profiling test based on DNA sequencing. Slightly different, but again, along the same lines. We can now take cancer tissue and we can tell you that particular chemotherapies aren't going to work. The study on the left, Herceptin plus adjuvant therapy for human epidural growth factor receptor positive breast cancer. So if you have the Herceptin receptor in breast cancer, HER2 receptor, excuse me, you are given Herceptin and you have an incredibly good chance of survival with early detection. We would not be able to know that without the power of genome sequencing. Now, if you are HER2 new, you don't have it, then there's other approaches, and giving you Herceptin isn't going to help. And so we're starting to link drugs to your genetics, and that's called pharmacogenetics, and that's actually something that is happening right now and is really important. It allows doctors to say, based on your genome profiling, you know, you're not going to do really well with this acid reflux drug because you can't metabolize it. You're not going to do well with warfarin or Coumadin because it's going to cause excessive bleeding, and so we're not going to give that blood thinner to you. We're going to give something else. And that's a super powerful aspect of genetic sequencing that we don't often talk about, but is happening behind the scenes. This happening at Foundation One, this happening with the knowledge of your early cancers being genotyped, and then the doctor, the oncologist, determining your treatment therapies with super good survival in these particular instances. 23andMe took their massive 1.4 million person data set, and they just ask you questions. You know, hey, do you sometimes feel like absolute garbage? Yes, I sometimes feel like garbage. Is it on a Monday? Yes. All right, well, that's probably because the weekend's over. Is it just random? Maybe there's something to that. And they start probing you with just simple questions. And they get 2 million questions a week answered from their 1.4 million person data set. They don't know who you are. They just know that you're an age and you're either a male or a female. But from that, they're able to now determine 15 new, this was a landmark study that just came out about 4 months ago, 15 new genetic loci for really profound problem in healthcare, which is depression. And so those were not known by any of the other studies that were happening. And they, again, this is biased to a specific population, but those studies can now be followed up on other populations. Those new genetic loci can go to the drug companies and they can start saying whether or not they can build drugs to them and start influencing the outcomes from major depression. And so this, to me, is the promise of the future. It's the promise of why we're collaborating with 23andMe, why we hope to augment their data set, and why we hope to have our own data set augmented. And I know I've gone a few minutes behind time, over time, but I'm happy to stick around and answer as many questions as you have. I thank all of you who are participating. Your history is helping us make history. Keep in touch at partners.renown.org. As we hopefully get new funding, we will be opening up the study to more and more participants. And with that, thanks for your attention, and I'll answer any questions. Yes.
Mine said 83% of the population were more likely to be Neanderthal than me.
Yes.
So that sounds like I'm not very good.
No, I don't. I think it's not about being good or bad. In cases of men, to make it like really personal, the more Neanderthal you are, the less likely you have a lot of back hair. That's the Neanderthal aspect of 23andMe is really more about origins and how we've migrated, but there are aspects of it that may impact your health. I think it's just a cute statistic they like to throw out there.
Okay, so right now you don't really know whether one's better or not.
No, we don't. We know that there are certain associations on traits that our Neanderthal ancestors had that affect height, that affect things like the fineness of your hair and also the volume of it in certain places, to get really technical. Any other questions? Sir?
I was looking at some of the markers on my report, which I already received, and I didn't see anything regarding Huntington's. So which diseases do you actually included in this report versus the ones that you said to leave out?
So I don't get to tell you what diseases are not included. The only carrier statuses that are included in the 23andMe reports are those that are FDA approved for things like cystic fibrosis and Bloom syndrome, and these are carrier status. So that means if you have the particular SNP, and you're a carrier, you would need to act accordingly. And so the process of getting those studies FDA approved are part of the problem in our $3 trillion healthcare system, $3 trillion annually. And why all of that information isn't available to be digested is a problem that is a constant battle between companies like 23andMe and the FDA. So the reports are those carrier statuses, and as they increase, as they get more FDA-approved trait reports, wellness reports, so there are some reports there on drug metabolism, which are important. More carrier statuses will come online, and they will just communicate with you. And that's what's really awesome about their platform, is as they get FDA-approved information, you receive it. You don't need to go to your doctor. They will send you an email and say, hey, I know they sent emails to certain populations who answered on the depression study. And they said, we published the study. And it is open access, and every single person in this room can read it. And here it is. And that's, I think that is a level of empowerment that's really important. Some doctors will tell you that perhaps that's too much information. I think that's the slippery slope of we're not asking to impact people's decisions or limiting healthcare options by genetics. That is not happening. And in fact, not a single person at Renown has access to any of the genetic information from 23andMe. And the reason for that is good data security. But as the FDA becomes more comfortable with the platform, with the association studies that they're doing using what they call their PheWAS platform, Phenotype-Wide Association Study, they will make more and more reports available to people. But all of the reports there are FDA approved. And that's the only FDA approved direct-to-consumer genetic reports out there. And that's not to plug 23andMe. I mean, you can also take your 23andMe results and send them to a company for $5, and they'll extrapolate and freak you out about your information. I wouldn't recommend doing that. But you guys can duke it out. Rock, paper, scissors. Who wants to go first?
So does certain drugs, can they damage your DNA?
Sure. Chemotherapies absolutely can damage your DNA.
I mean, not like chemotherapy. I'm just saying, street drugs, say a drug population, certain.
Chemicals?
Yeah, chemicals.
Yeah, I mean, I'm trying to figure out a sensitive way of answering this. Let's take tobacco, for instance. That's an easy drug. Nicotine is a drug. If you look at certain lung cancers and certain melanomas, those are skin cancers, you will find very similar genetic properties. And the reason for that is because the crap, excuse my scientific expression, in tobacco has the same oxidative impacts on lung as the sun does on your skin. And so absolutely there are other chemicals out there that are found in both recreational drugs, but also things that are in food that cause the damage to DNA, absolutely. And those things can be identified chemically as complicated molecules that don't have, origins in. GMO is a different. That's a different lecture too. No, it's more, additives that, have, for example, dangling nitrogen molecules on them that can be oxidized and then become, highly volatile in the cell. So oxidants that are found in both drugs and food products. Processing stuff tends to be bad, and non-processed stuff, which has lots of antioxidants, tends to be good. It's a very complicated question, though. I mean, chemicals, yes, there are certain chemicals that cause damage. Hydrogen peroxide causes damage, H2O2. It's a nasty oxidant. Once it gets in your belly, it gets neutralized, and it's not an issue. But in your mouth, the reason why it foams is because it's causing, a lot of chemical reactions.
The question and your response about Neanderthal proportions prompts this question. I've heard that a sizable portion of us, 10%, are related to Genghis Khan because he wasn't shy about spreading his seed through Europe. Can you verify?
The question was, are 10% of the people in the audience related to Genghis Khan? There is a last common ancestor. That is a fact of procreation. And if you choose not to believe in that, then I guess it's not a fact. But yes, we all have a common ancestor, and how far back you have to go to the last common ancestor. I guess it's possible if Genghis Khan was prolific, then a lot of people could be related. But the concerns for genetic relatedness and the problems that occur, are within shorter generational confines than back when the Khan was out there romping around.
Don't we already know that some of the negative health outcomes for Nevada is related to the low density of healthcare professionals as well as the low educational attainment of the population?
Yeah, I think that's, if you look at the statistics for educational attainment, they really are improving, and they're not that dissimilar to other states with relatively poor health outcomes. Certainly, if you don't have access to, good, a good doctor to put a stent in you, and you have coronary disease, then yes, your outcome is going to be affected, and that probably increases that number that you saw there for heart disease. But we also know that the vast majority of it is behavioral and probably related to multiple factors, one of which is related socioeconomically. A link to socioeconomic is diet. It doesn't necessarily need to be, and the next brilliant person who can take this data and apply a social twist to it and start figuring out how do you nudge people to make behavioral changes is going to be very popular in population health circles, because that's the gorilla in the room, is that all of these hazard ratios that accumulate for diseases are minuscule compared to the big ones. And so we can talk about genetic links, and some of them are very profound. But in general, if you treat yourself poorly, you're going to be a tax on the healthcare system, if you let those problems go. Whether it's the case of my father with colon cancer, or the person who's completely disregards themselves and has to go back and back and back for problems related to diabetes, problems related to COPD, cardiac disease, et cetera. So it's the way out of your question is it's complicated, but I don't think we can just blame poor education on those statistics. We need to dig deeper. I think that's a crutch. Sir?
I noticed that in poor neighborhoods, I guess, there's a lot more like liquor stores and convenience stores and things like that they really don't have access to. Well, not that they don't. It's more farther away to get to a store that has healthier food for you were talking about zip codes and stuff.
Sure.
And it's the funny thing about our food industry is that, you know, the cheaper the packaged good, the more processed it is, and the more bad stuff it has in it, and the more things on the ingredient are listed. You know, and they list all these weird chemicals and bleaches and stuff like that aren't really, you know, good for you. And I think that kind of accessibility challenge in you know, you talk about the zip codes might be a contributing factor. You know, if you're poor and you have to rely on the bus or something, so, you know, the nearest good grocery store is not convenient for you.
Sure. And
So,
again, it's a multitude of factors related to, you know, aspects of urban development. You know, nobody. It's hard to blame the city planner for people's health problems, but the fact is nobody foresaw the growth that would occur in many, many, many areas of the United States, and that has resulted in, you know, what urban planners will call poor to no planning. And sure, there are studies that show that access to green space is really important for people's health. Sidewalks are important. Keeping sidewalks clear is important. We know that. How to
to vegetables.
access to vegetables, sure. The question is, how do you fix the problem? And that's beyond my degree, frankly. Yes.
When you were talking about the air inversion, I was wondering how does uranium and nuclear, there's been nuclear tests here in Reno, not Reno, in Nevada, how does that impact us?
I think let's take Fukushima for the best example. I mean, a massive release of radioactive material from the tsunami at the nuclear plant in Japan. And yeah, there was a plume of radioactive air that went across the Pacific and could be tracked. The numbers are so low compared to getting on an airplane and going up into, at 35,000 feet, that the risks are relatively low. Now, living in a basement that has poor ventilation and has aging granitic rock and has radon is a different story. That's real ionizing radiation that causes profound health problems. So I think the link that I was trying to make to geology was less about the anthropogenic impacts of our use of radioactive material and more things like radon and nitrates in well water. Nitrates are highly oxidative and they cause problems. But sure, if you were hanging out with fat men and little boy, and you were working at the test site, you were exposed to a tremendous amount of ionizing radiation. And the doctors who work in radiation facilities monitor that extremely, they monitor it tremendously because of the fact that it destroys DNA. But the concerns for me as a scientist and with knowledge of the environment would be more about the quote unquote silent killers in the rocks rather than the accidents. Not to say accidents are good, but the radon is much worse than those other things.
How do you deal with that age-related phenomenon? As you get older on that, you're losing people because of death or other associations. So if you go from 1 to 80, 90, you get a skewed population in an upper level.
Sure, and
how do you deal with that?
So the idea behind doing a population health study unfortunately does not fit on the political calendar because it must be multi-generational to be really successful. And so the way that we talk to our funders about this and to the community is that to leave a lasting legacy, we really need commitment from the healthcare providers and the scientists to build up data so that we can track people. And again, I use the word track in a scientific sense, not in a, some, nasty, Big Brother 1984 sense. That's coming in a few months. So the idea behind, capturing a population is to watch them grow old and understand their outcomes and understand that, the farmer in Winnemucca who had the exact same genetic profile, so to speak, as the person, who was, a bank teller had a different outcome. And if we have enough of those people, we can start figuring out that it had to do with some aspect of the behavior. And the follow-up of families becomes important down the line. So an example would be if we happen to come up with a specific mutation in a rare genetic disorder that was in northern Nevada. To validate it, we would need to go back to, either mom and dad or grandma and grandpa and uncles and aunts and track and see, is this something that is truly inherited, a la Gregor Mendel, or is it something that was, a spontaneous, somatic mutation, like things that cause cancer. So yes, the 93-year-old person, God willing, is going to be here for many years to come. But, as we track people and population cohorts as they get older, we will start continuing to replace them, so to speak, in a scientific word, with, with new participants. And that's why this needs to be a true community commitment.
Are you familiar with the NIH WHI study that was done partially here in Reno at UNR?
What's WHI initials? I'm like acronym deficient.
Women's health?
Yeah, yes, absolutely. So
we're into it more than 20 years.
Yep.
That data, I'm sure, would be available for Reno.
Yes.
Because there were a lot of us in Reno.
Yes, and I can tell you that we just helped contribute data to new funding for some aspect of that study related to the impacts of HRT, hormone replacement therapy. So yes.
Well, there's a study too for the health and strength. It's WISH, W-H-I-S-H now, that incorporates exercise, food, behavior.
Yeah.
And that's just started in the last couple of years.
Yeah, so the other idea behind the infrastructure of this is that those data will become available to researchers to leverage and
Yeah.
really use.
But that could be beneficial with this application.
Absolutely, and vice versa
Yeah.
is what I was
Yeah,
implying.
exactly.
Right.
One more, maybe our last question.
So, I'll take the two, there's two people behind you who haven't asked, so I'll just hit those two and then I'll be done.
Just to start first, how many participants do you have currently?
So I think right now we're at about 8,000. We'll be going to 10, mostly finished by Thanksgiving, which is an astonishing enrollment. And then the hope is funding will increase and we'll gain more availability.
That goes into what I was, second part, is kind of the goal with this to incorporate as many people that are willing to participate and be active with it as possible?
That would be one goal for sure. There are certain just realities of doing statistics on disease and outcomes that require the power of numbers. So the more the merrier. But as you can imagine, the more the merrier means that it's also expensive. So stay tuned.
I just had a clarifying question about the correlation, and if there is a correlation between well water and pancreatic cancer.
Yeah, there's no known causative link between well water and pancreatic cancer. But the idea behind looking at cancers that stick out, so to speak, in northern Nevada and really understanding aspects of our environment, altitude, it's a reality, 4,200 feet and climbing wherever you are. The inversions, well water differentiation. So there are different, chemistries in the well water. People have talked about a Fallon cancer cluster. There are varying degrees of nitrate in well water which need to be remediated to be EPA drinkable. And so given that DRI has a strength in those data, we can start linking them, and that just isn't being done. But it was not to suggest, which is why at the time I specifically said, I'm not suggesting, but it offers new insights into, profoundly problematic diseases. I mean, pancreatic cancer is a terrible disease.
My goodness, this has been, let me turn it on. This has been a wonderful, wonderful and informative evening, Dr. Grzymski, and it's one of our longest presentations, but I mean that in a positive way. So I want to thank you, and I would like to say that we did offer Dr. Grzymski a small honorarium, and he has offered to give that to TMCC students. So we'd like to thank him for coming, for giving his time, his knowledge, and for also that generosity. So thank you so much. See ya.